So I'm going to talk to you guys about some of the major systemic arteries and veins that we should know about, and then we'll talk about some of the different types of arteries and blood pressure and things like that. Okay, so in terms of, we have head and neck vessels, we have upper extremity, thoracic and abdominal, and pelvic, and then lower extremity vessels. Your book probably breaks some of these down, and I will also have some slides that have images with all these different things. But I wanted to take a second to use this app to kind of give you guys a tour of some of these vessels that you should know, and so we have a good understanding before we move forward. So, talked a little bit about the aorta. So the aorta has three prominent branches that come off of it. This is going to be the brachiocephalic trunk, and you can see here the internal or the right common carotid, which is going to branch into your internal and external carotid arteries, and this is the carotid sinus, which and the carotid bodies, which are going to be at that bifurcation. Internal is going to supply blood to the circle of Willis. If I were to take away the skeletal system, the middle cerebral, the carotid arteries come up and become the middle cerebral artery at the end of this branch. If then we are going to follow down the external carotid artery, this is going to provide facial blood flow, definitely all the different glands of the face and oral cavity, and the external structures of the head and scalp. Okay, if we look here, these arteries that branch up off the, follow the cervical spine. These are going to be the vertebral arteries. So if I bring the bones back, or if we actually look at the X-ray, here we can see the where they travel through these small passageways, these little foramen in the vertebral columns, and as they travel up, they become the posterior portions of the circulation to the cerebrum, posterior cerebral arteries, basilar artery, etc. Okay. Veins of the neck, we have the big ones to know: internal and external jugular. So internal is going to feed directly from the sinuses within the cranium that are draining blood from the cranial vault. And then we have the internal jugular arteries, which are the ones that we can start IVs in the field. External jugular, or not arteries, external jugular veins. These are the ones we can start an IV in. The internal jugular is a central line. If you were to put a line in there, that would be central access. And you can see they sit right next to the carotid arteries. So when we look at these on the ultrasound, if you stayed after the other day and you got to see that, that's kind of the structures you're looking at. So those are the main veins. And then we're going to have the subclavian vein. And these are where the jugulars drain into. The reason the external jugular is so great for not peripheral IV, but for an IV, is because we're getting very close to the central circulation, where the internal jugular is just a little bit closer. And the subclavian vein basically is draining the head and neck as well as the upper extremities. And these are draining right back into the superior vena cava, which is going down into the right atria. If I flip around, the second branch again is the left common carotid artery is the next branch from the heart off the aorta. So we have the brachiocephalic trunk, and now we have the left common carotid. It's going to mirror the common carotid from the right side. And then we have the subclavian artery on both sides, which on the right is going to branch off the brachiocephalic trunk. On the left, the subclavian is going to branch directly off the aorta. And then these are going to branch into our upper extremity arteries. So we're going to have the axillary artery, which is going to supply axillary blood flow. It's going to branch into the brachial artery, then radial and ulnar arteries. And the radial and ulnar arteries are going to then branch down and supply blood flow to the hand. The veins of the upper arm, again, we have the brachial vein, or basilic vein, sorry, and the phallic vein. These are the big ones that we follow in the antecubital space when we're starting IVs. And The anatomy of these are kind of important. The arteries run deeper in that fossa and branch up into the medial aspect of the arm and kind of run along the inside of the arm. And then there's our radial and ulnar arteries that are supplying blood to the hand. And then the basilic vein and cephalic vein are basically branching back to the subclavian vein. Okay, let's look at the descending aorta now. So this is going to be riding right along the spine, like I told you guys in the class. So it rolls right along the spine. Some major branches of the descending aorta. So let's add some more layers of the arteries. Boom. Okay, I'm going to take off the venous layer so we can sort of look at the arterial layers. It's a lot of layers. So in the posterior side, we have the costal arteries, which kind of follow the superior border of the rib, these intercostal arteries, which is why when we stick needles and things in the chest, we go over the top of the rib, not underneath. These branch off at each costal space, and they also supply blood to portions of the spinal column. And there's a few other arteries that do this as well, but what I want you to focus on is some of the major arteries of the thorax and abdomen. So in the thorax, we have an artery called the bronchial artery. Try to find it. Esophageal artery. This is our esophageal artery. Looking for the bronchial artery. It's going to supply blood flow to the lungs. Thoracic artery, the anterior portion of the chest. Esophageal one. Okay, there we go. Esophageal branch, right bronchial artery. And then here's the other part of the bronchial artery. So these initial branches right off the descending loop are supplying blood flow to the lung tissue for actually bringing oxygenated blood to the lung, not for gas exchange, but to bring blood to those cells. And then our next branches in the thorax are going to be like esophageal artery, which are going to supply blood to the esophagus. Okay. As we move down through the diaphragm, right after the diaphragm, there's some major arteries. Phrenic artery is going to supply blood to the diaphragm. So this is actually going to be still part of the thoracic arteries. But as we branch just below, again, inferior wall of the diaphragm, we have something called the celiac trunk. And the celiac trunk contains three arteries. It has the gastric artery, the splenic artery, and the hepatic arteries. This is going to supply blood flow to our spleen, liver, some of our liver, and our stomach and pancreas, as well as some of the biliary structures. So huge major artery, and this can definitely be damaged. Next, as we go down, we'll see the mesenteric artery, and this supplies blood flow to something called the mesentery, which is like a lattice-like network. You can kind of see this sort of structure. The mesentery is going to provide blood to the intestinal tract, as well as some of the primary digestive organs. And there's the superior and inferior mesenteric arteries. Okay. Renal arteries. These are early blood supply. They supply blood to the kidneys and adrenal glands. Okay, then as we branch down, again, we have the inferior mesenteric artery. So again, lower structures of the GI tract. At the branch of the aorta, so the abdominal aorta as what we're looking at now, and then there's a bifurcation and it becomes the iliac arteries. And there's right and left, and they're the common. And then the iliac arteries, their main branches as they go down, as they pass through the opening in the pelvis, becomes the external iliac artery. This is common iliac artery. And then as we branch down, we have the femoral artery, left and right. This is running down the medial aspect of the leg. And then your external artery is called this is the deep femoral artery. And these are the main blood supply going to the lower portions of the leg. Veins we should look at in the abdomen, thorax. Let's take that down a notch. Okay, so superior vena cava is fed by the iliac vein. So luckily, a lot of these match the arterial name. And then we have the inferior vena cava, which is bringing blood back to the heart. Then we have the femoral veins, which run right along the femoral artery and then branch into that iliac vein, follow it through the pelvic cavity. In the lower extremity, we have an artery that branches off that follows the calf, which is called the saphenous vein or the great saphenous vein. And it runs basically just from about the upper part of the leg all the way down to the lower extremity. And then this vein here, again, femoral vein. So these are the ones that I would just know pretty well for large anatomy. All right. Last little bit of this is talking about the vessel anatomy and some of the different types of capillaries that we have. So the basic vessel structure is we have three different layers. And so in arterials, we have, or arteries, we have a different structure compared to a vein. So in the artery, we have the tunica externa, which is a dense connective tissue, irregular connective tissue. Then we have the tunica media, which makes up our muscle layer, and then we have the tunica intima, which is the endothelial layer, or actually kind of the living layer of the blood vessel, where all the functions are happening. And then there's an elastic membrane that separates the tunica media and it connects the tunica media and intima. And then that externa also contains a structure called the vasovassorum, which is where the nerves and blood vessels that actually supply the blood vessel with its own blood supply and nervous system supply surround the artery. In the vein, you'll see you have a much thicker tunica externa and a thinner tunica media. And then there is no elastic layer in between the connective tissue layer, in between that intima and the muscular layer, which the connective tissue layer makes that vein bouncy. And lacking that structure between the media and the intima and the thicker muscle layer makes that vein like collapsible. And so when we push on a vein, it collapses. Where we push on an artery, it feels a little bit more rigid. The sympathetic nervous system fibers that extend essentially through this layer are what are going to innervate that smooth muscle to help us with vasoconstriction. And then as we get into something called the arteriole, which is a smaller level of artery before we get into the capillary bed, we have a very thin external layer and a thick muscular layer, and then a very thin endothelial layer. Okay, there are three main types of arteries. We have an elastic artery, we have a muscular artery, and then we again have this arteriole. The three main types of arteries are found in different places. So elastic arteries tend to be like the superhighways. These are the large arteries that have lots of elastic fibers in them. They are not, they are transporting blood like the aorta, and they tend to be moving blood to then a smaller artery. So they don't provide much gas exchange, and they actually don't change diameter a whole lot. So there's not a lot of nervous system innervation where we're getting a lot of muscle constriction of these. And they exist to, they have a lot of stretchy elastic wall fibers in the tunica media. You can see this blue stuff, and a pretty thin external layer. And a lot thick elastic layer, again, where lots of stretchy connective areas dealing with high pressure. Muscular arteries are going to be what also we call the communicating arteries. And these are like, if you think about like a highway system where you are traveling on a highway and you exit the highway and then you get on like a smaller road, you're trying to get to where you're going. That smaller road now is like the communicating artery. And the communicating arteries tend to have names like for where they're communicating with. So renal artery, hepatic artery, splenic artery, gastric artery. These are all telling you where they're supplying blood to, and they're communicating blood to those areas. These arteries have a thick external layer, much more vascular structure, and nervous system structures. So they do respond to our nervous system. They do constrict. They can shut blood flow down to these areas by constricting these vessels away. We have a thick tunica intima layer with the connective tissue layer of our tunica intima, and they're moving blood to those tissues. Once we get into the tissue, then we're going to have the arterioles, which are going to branch down into the capillaries. And so much thinner external layer, much thinner artery. These are very, very, very small in diameter. And are actually going to move blood to where the diffusion of nutrients is going to happen. Okay, capillaries, there's a couple types of capillaries. So three main types. We have continuous, we have fenestrated, we have sinusoid. And most of our capillaries in our body are this continuous. And then in special areas, we have sinusoidal capillaries and fenestrated capillaries. And so depending on the location or the function of the capillaries, we're going to determine what type is there. So most common in all of our vascularized tissue is continuous. These allow for some transport of gases and nutrients across the membrane. You can see, though, it's fairly continuous in that there's pretty tight junctions between the cells of the endothelium. Even though it's squamous, meaning it's one simple squamous layer, it does still regulate pretty tightly what can get in and out. And again, if, for example, I have inflammation, I can increase these spaces and have more leaking of things out of these capillaries. Fenestrated capillaries have little pores in them, and these are going to be found in places where there's lots of filtration. So one important place is like in the kidney, in the glomerulus, where we're having blood move through those capillaries. These pores allow for filtration of stuff through those openings, and it's going to have a less, still tightly controlled, but it's going to let more things out of the capillary. And then sinusoidal capillaries have larger components of spaces between the cells. So there's actually large gaps. And these are going to be found in places like bone marrow, lymph nodes, spleen, liver, where there's lots of things moving into the cellular spaces. As we move from an arterial to a capillary. So this is kind of what a capillary bed looks like. You have an arterial, and then you have this smooth muscle, this sphincter. And then what you have is something called a meta-arterial, which is the transition between the arterial and the capillary bed. And essentially, we can prevent blood from going into these capillary beds by shunting blood by clamping off these small sphincters and preventing blood from going for diffusion. So, for example, during a sympathetic response, the smooth muscle gets stimulated by adrenergic receptors to constrict. And this is going to cause blood flow to shunt away from these capillary beds, this white part of the vessel. And that means gas exchange or diffusion or things can't happen. So this happens all over. For example, in the lungs, if I have poor ventilation of an alveoli, what's going to happen is my capillaries will shunt blood away from those alveoli to other parts of the lung that maybe have better blood flow. So that's just an example of how that might work. And then this is called an arterio-intravenous anastomosis, which is an ability to bypass the blood flow again to these to this thoroughfare where it can distribute into these capillaries. And then on the other end, we have the venule, and then the venule is going to go to larger veins, and then larger veins to the central venous structures. Okay, veins, like at any one time, about 60% of our blood volume is sitting in our veins. And then our spleen actually stores a lot of our blood as well. So it's moving through the arteries pretty quickly, but the veins, moving through the veins much slower. And veins, we have large veins, medium veins, and then venules. And in large veins, these are like our vena cava, again, communicating large volumes of fluid from A to B or blood. Then medium veins are kind of picking up from the venules and moving back towards those central veins. And again, they're going to be named for the tissues that they're draining. Saphenous vein, the cardiac sign, coronary veins. These are like small, medium-sized veins. The vein, the cephalic vein in the arm where we're starting IVs. These veins have valves. The smaller, medium-sized veins are going to contain these little semilunar valves, and those prevent the backflow of blood. They're just one-way valves that open as blood moves forward, and then it closes to prevent backup of blood. When these veins look at the structure, we have a much thicker external layer. So this connective tissue layer gives that vein the bouncy feeling, very thin muscle layer. Not in terms of innervation from the sympathetic side, not a significant amount of constriction necessarily happening in our sympathetic side within the venous structures. Veins are driven by venous circulation is driven by a couple different things. So we have the arterial pressure, which is going to drive blood flow through the body. Then we have the muscular pump, which is like the movement of our muscles compressing and relaxing on those veins, creating positive and negative pressure. And then the last pump we have is the respiratory pump. And that's going to be kind of the final pump that's pushing the blood back towards the heart from the vena cava and the thoracic space. So all three of those things together create our venous pressure. Our arterial blood pressure is measured usually in a systolic and diastolic. And that arterial blood pressure, when we take a blood pressure, is measured by measuring the peak pressure during systole and then the peak pressure during diastole. And so basically, when we're talking about systolic and diastolic pressures, we're looking at the pressure during constriction of the heart and the ventricles, and then the relaxation of the ventricles. Mean arterial pressure essentially is diastolic plus the pulse pressure, which is the difference between the systolic and diastolic divided by 3. And that gives us a average, or this like little line here, of mean arterial pressure between and the pulse pressure is the difference between these 2 points. When we take a non-invasive blood pressure on somebody's like cardiac monitor, and you put somebody on that and you hit NIBP, and that is actually calculating the map and finding the map and then calculating your systolic and diastolic. So it obtains the map first and differentiates those two by reversing this equation. So your map is actually pretty good on your cardiac monitors. The other way you can measure arterial blood pressure is by sticking an arterial line in somebody and hooking that up to a transducer and measuring the continuous pressure. And those get measured continuously. Inside the vessel, the pressure has a couple effects. So as blood is moving through the vessels, we have pressure being exerted on the inside of the vessel wall. It's called hydrostatic pressure. And then we have the pressure pulling back in, and this is going to be essentially driven by our oncotic gradient. So the oncotic force is going to help reabsorb that fluid back into the vessel, or maintain it in there. And that's going to be our albumin, sodium, things like that. As hydrostatic pressure happens when we're pushing water out, that's called filtration. And then the reabsorption back into the vessel is driven by the colloids, the stuff in our blood that's making it have more tonicity. So it becomes slightly that tonicity is more hypertonic than the extravascular space. So that helps retain that fluid within there. Essentially, as we talk about filtration and things, these are mechanisms that can lead to edema, right? When we have excess filtration and low reabsorption pressure, low osmotic pressure, that's going to lead to increased fluid leaking out of vessels. The things that regulate our vasculature, there's a big list. You don't need to memorize this list, but sympathetic and parasympathetic stimulation. Parasympathetic does not cause much in the way of vasodilation or constriction. The primary function of this is going to be the sympathetic control. And so we either have an alpha or a beta 2 receptor within the smooth muscle. If there's a beta receptor, it's going to increase the diameter of the vessel. If it has an alpha receptor, it's going to decrease that and cause vasoconstriction. Our endocrine functions, epinephrine is basically a sympathetic stimulant, so it stimulates the alpha and beta receptors, especially norepinephrine, similar. Angiotensin is an endocrine uh, functional vasoconstrictor that is part of the renin aldosterone angiotensin system that causes vasoconstriction. And then we have a peptide released natriuretic peptide that can potentially have some effect on vasodilation, and ADH again increased vasodilation for perfusion of the kidneys. Or sorry, ADH is going to be a fluid retention antidiuretic, opposing fluid kidney urine production. And then lots of other factors that can potentiate these things like nitric oxide and things like that. There is a negative feedback mechanism, essentially, like as decreased blood pressure and blood volume happens, we have this sort of effect. So we get the endocrine side that's going to drive ADH, angiotensin 2, aldosterone, erythropoietin. These are going to do everything to increase blood volume. So ADH holds on to water. Angiotensin 2 is going to squeeze the vessel. Aldosterone holds on to sodium so that we retain more fluid. EPO increases blood cell production. All that tries to restore homeostasis. Then over here, we have the nervous system mechanisms. So we have baroreceptors, chemoreceptors that get stimulated when blood pressure drops. Then we're going to have increased heart rate, increased vasosympathetic control of the stimulation of the spinal cord to do more sympathetic stimulation to constrict blood vessels and increase cardiac output. So both of these things work together to restore homeostasis. All right, that's all I want to go over. I gave you guys a little tour of the arteries already, so keep on studying. Let me know if you have any questions. Okay, so as these platelets are sticking together, they're sticking together by the use of something called ADP that gets exposed, and it's going to help promote more platelet aggregation and also help the binding of these platelets to one another and to the von Willebrand's factor. So ADP is something that when we give aspirin to a patient or any NSAID, we're suppressing basically this ADP exposure because it is made through that cyclooxygenase pathway that we're blocking with NSAIDs and aspirin and things like that. So as they're sticking to the von Willebrand's factor, they're forming this plug. And this plug is now kind of created a stop in the blood flow out of the vessel. However, this plug is very susceptible to damage and it's very susceptible to pressure. And if it does not get reinforced, we're going to break the dam essentially and we're going to rebleed. Very important to understand that we have to stabilize a clot with the very first plug we form, because after the first plug, it's like if you're trying to bake a cake and you only have like so many ingredients, the best chance of making the best tasting cake is going to be that first where you have all the best ingredients. But if you start using up ingredients, you just ran out of eggs, now you're trying to make a cake without eggs, or you're trying to make a cake with like some other kind of like all you have is like weird gluten-free flour in the back of your pantry, it's not going to be a very good tasting cake. So that first chance is the best chance for the best plug. And this is why early whole blood in particular in patients is so important, because we can promote not only vessel repair by helping the glycocalyx with the plasma portions of the blood, but also we are making sure that there is adequate materials to form that clot, and we're not diluting those by giving an isotonic solution. Okay, so